First of all, I want to appreciate President Harp for giving us very precious opportunity. Our society CSRS AP was founded in 2010 as a sister society of CSRS and CSRS European section. As we are the youngest society, we have been struggling to catch up even a little in the history of about 12 years. As you know, more than 60% of the world population lives in Asia-Pacific region, and many patients are suffering from cervical spine diseases. Among them, there are many intractable cases involved. Today, we want to introduce 5 categories of intractable cervical disorder we have confronted in Asian countries. Our education committee selected 5 surgeons who are leaders to treat them in each country. First topic is infectious diseases in cervical spine, presented by Dr. Rajasekaran from India. Second is severe deformity, explained by Dr. Suk from South Korea. Third topic is hyperkinetic cervical spine, mainly in athetoid cerebral palsy patients. I am in charge of this topic. Next intractable disorder is drop head syndrome. As the aging society advanced, this disease is increasing in Asian countries, including Japan. Then Dr. Ishii will present it. Last topic is tumors, including of metastasis at cervical spine. China, the world's most populous country, is actively working to treat very difficult tumors in cervical spine. Dr. Feng Wei from China is a speaker of this topic. As you know, cervical spine locates between head and heart and play an important role as a human lifeline. Therefore, we cannot run away from intractable cervical disorders. That is the reason I pick up them of CSRS AP 2023 as cervical spine between head and heart. If you are interested in our struggles and experience, please join our meeting in Yokohama, Japan.
Hello, everyone. I'm Dr. Feng Wei from Peking University Research Hospital. My topic today is tumors including of metastasis at cervical spine. Primary tumors of cervical spine are rare and difficult to diagnose. The goal of the surgery is palliation or cure. Pathological diagnosis is premise of treatment. A CT-guided biopsy can accurately obtain the tumor tissue. The surgical strategy is to be made according to Anakin staging. For the benign S1, we can just undertake observation or do surgery without damaging the structure, like PVP or radiofrequency ablation, or do decompression surgery. For example, it is a 25-year-old male with back pain for a month. CT and MRI of cervical spine show that pathological compression fracture was caused by lesions of C7 vertebral body and right lateral mass. Langhand histiocytosis was diagnosed by biopsy. It is a kind of self-healing disease. We just observed and gave external fixation. We can see that 1 year and 4 years follow-up, the bone healed and ossified itself. The patient recovered from the pain completely. For benign S2, we can do intralesional excision. It is an 18-year-old female with C4 and 5 lateral mass osteoblastoma. We did intralesional excision of C4 and 5 right lateral mass and fixation by posterior approach. The internal fixation was intact and the tumor did not recur after 2.5 years. By the way, sometimes the surgery is not the only way. It is an 8-year-old girl with neck pain for 7 months. X-ray film and MRI showed extensive destruction involving C4 vertebral body and posterior structure with fracture and dislocation. Aneurysmal bone cyst was diagnosed by biopsy. We did intralesional injection of doxycycline 2 times. 1 year later, the lesion was significantly reduced and ossified. 2 years later, the lesion was basically ossified. The girl lived normally without breast and neck pain. For the tumor of benign S3 or low-grade malignant tumor or highly malignant tumor, we should do en bloc resection. If en bloc resection is not feasible, intralesional resection and radiotherapy should be undertaken. For the highly malignant tumor, we should use chemotherapy. For example, it was a 27 years old male with epithelioid sarcoma of C2 and 3. The surgical plan was an en bloc resection through anterior, posterior, anterior 3 approaches, sacrificing left vertebral body and C3 and 4 nerve roots. In the first anterior approach, the cervical spine was extended as far as possible in order to expose the cranial end of the soft tissue mass. In this approach, C2-3 and C4-5 intervertebral discs were resected, and the right vertebral artery was released. In the posterior approach, the lateral mass involved by the posterior tumor remain intact and completely disconnected from the proximal and distal lateral masses. For the second anterior approach, the C3 and C4 vertebral bodies were totally removed after ligating the left vertebral artery, and the 3D printed artificial vertebral body was used for reconstruction. En bloc resection with negative margin was obtained. After the surgery, the patient underwent radiotherapy and chemotherapy. No tumor recurred in the 2 years follow-up. For malignant tumors that cannot be removed with an en bloc resection, intralesional resection and radiotherapy were used. For example, it is a 44-year-old female of C2 chordoma with huge pharyngeal mass. We did posterior fixation and anterior intralesional resection with postoperative radiotherapy. The patient lived with high quality of life. But 7 years later, the tumor recurred after the index surgery. We did another posterior tumor resection and postoperative SBRT. Right now, the patient lives normally already for 2 years. Another kind of tumor of cervical spine is metastatic tumors. Cervical metastasis accounts for 8 to 20% of spinal metastasis. The goal of the surgery is palliation. Resection is general intralesional. Adjuvant therapy may be available. We recommend PET-CT for quick diagnosis, for it is sensitive and it is very useful in screening tumor source and tumor load. For example, it was a 41 years old female with neck pain and left arm pain for 2 months. PET-CT revealed gallbladder cancer with C4 metastasis. Before the surgery decision, we should assess the degree of the spinal cord compression, spinal ability, and life expectancy. We use normed framework to select treatment. When posterior compression occurs, we can do posterior decompression and fixation. It is a A 50 years old female. She complained neck pain with numbness of right arm for half a year. The PET CT showed right lung cancer with C2 to C4 metastasis. We did posterior decompression and occipital of cervical fixation. For the tumor with single level vertebral body involvement, we can do anterior corpectomy and reconstruction. It is a 76 years old male. He was diagnosed with lung cancer with C6 metastasis. We did ACCF of C6, post-operative SBRT, and target drugs. The tumor was stable in 3 years follow-up. When multiple segments of or the cervicothoracic segments are involved, we can do posterior decompression or separation surgery. It was a 56 years old female with neck pain and arm pain with weakness for 4 months. The PET CT revealed a liver cancer with C7 to T2 metastasis. We did posterior separation surgery and fixation. The patient recovered from back pain and arm pain immediately. So the take-home message are, for the primary tumor, pathological diagnosis is critical for treatment. To do the appropriate surgery according to the Anakin staging. For the metastatic tumor, assessment of spinal cord compression, stability, and life expectancy are important. Separation surgery and post-operative SBRT provide good local control. Systematic treatment is needed. Thanks.
Thank you, Dr. Feng Wei. Unfortunately, he is not in this room. So please discuss on this topic. Do you have any comments on the tumors of cervical spine?
After the surgery, we did adjuvant therapy, for example, radiotherapy, and then I'm not sure that when I should start the radiotherapy after the surgery. Do you have any idea about that?
Dr. Ken Ishii, do you have any opinion?
Sorry about that. Sorry. So I think the in case of C2 chordoma, so we used to perform the resection surgery, but recently we use the heavy particle therapy, something like that. So how how about situation? How about strategy in the Asian countries, guys?
Okay, so this session, the theme of this session is an intractable case. So at the end of this session, would you please say some comment when we confront of the intractable case? Dr. Suk, do you have any comments for young doctors?
Well, I think that every case is we should keep the principle, surgical principle, and that it will result in good surgical outcome.
How about Dr. Ishii? Do you have any comments for young doctors? Please mic on.
Oh, thank you. So in Japan, recently, the patient with drop head syndrome increasing. I heard that Dr. Suk in Korea is very clear. So, but the Asian countries in the future, probably the patient, the getting old, age-related changes, probably drop head syndrome is increasing. Probably we're gonna figure out some pathology and drop head syndrome and surgical strategy as well. Thank you.
Okay. So I have one message. So when we confront of the very tough case, we should observe and take very carefully examine the patient neurological condition. And after that, when we perform the surgery, we should keep original structures as much as possible and make reconstruction using such original structures. That is my most important message to you. So thank you for listening this session. So we enjoyed discussion. Thank you. Thank you, the lecturers. Thank you all.
Thank you.
Thank you very much.
Thank you.